to review the radiographic findings in various causes of acute dyspnea, and by so doing, to refine differential considerations based upon these imaging findings, to apply this understanding in the clinical context of the patient with acute dyspnea, utilizing a pattern recognition approach. What is dyspnea? Dyspnea is simply defined as shortness of breath or an awareness of breathing by the patient. And the causes can be functional, organic, or in fact, the most common cause is simply psychoneurotic, secondary to patient anxiety. The patients present with acute respiratory distress or shortness of breath or acute respiratory failure. And this is a daily clinical challenge for people in the emergency room and for us upstairs in the radiology department to interpret the imaging findings in these patients. What is the role of CT in acute lung syndromes? Well, first of all, with the heightened sensitivity of CT for disease detection, we can confirm the presence of radiographically occult disease. Similarly, we can confirm the absence of disease, which would lead one, which would lend support to a psychoneurotic cause for the dyspnea. Finally, we can clarify and characterize the chest X-ray findings, which allow us to characterize the lungs' response, refine the differential diagnosis to a few considerations, which is very helpful to the clinicians dealing with these patients. The indications, therefore, for CT would include a symptomatic patient with a normal or equivocal radiograph, or a patient whose radiograph has acute disease, but it's masked by chronic changes, or the findings are nonspecific. Now, I know that's somewhat blasphemous for a chest radiologist to say, but the fact is radiographs, chest radiographs, are very hard to read, in my opinion. And the indicator of that is if we all count quietly to ourselves, how many times a day do you use the phrase nonspecific increased markings? Radiographs are hard to read, and they many times in a variety of these entities look quite similar. So when we're talking about acute lung syndromes, we can divide the parenchymal processes into three large categories: vascular processes, infectious processes, and non-infectious processes. When we speak of vascular processes, we're considering pulmonary embolism, edema, ARDS, and Mendelsohn's syndrome. Infectious processes would include the atypical pneumonias, and non-infectious processes include hemorrhage, radiation, pneumonitis, inhalational and reactive airway diseases, acute interstitial pneumonitis, collagen vascular disease, drug reactions, and hypersensitivity pneumonitis. Because we'll be hearing about thromboembolic disease and reactive airway disease later on this morning, I'm not going to discuss those two entities, but we will discuss the other causes of acute lung syndromes broken down into the following groupings. So we'll begin with infectious causes. This would include atypical pneumonias, viral and PCP pneumonia, Legionella, and mycoplasma pneumonia. Viral pneumonias in the adult population are primarily due to parainfluenza and influenza viruses, with RSV, respiratory syncytial virus, fairly contained to the pediatric population. Parainfluenza and influenza are the cause of epidemic viral pneumonia in most adults. The infection moves through three phases, and the radiographic findings in a viral pneumonia are therefore going to follow along. The inhalation of the droplet nuclei is the point of infection. This happened to you this morning when somebody sneezed as you were picking up your bagel. The infectious particle invades the bronchial epithelium and causes epithelial inflammation and necrosis. Peribronchiolar inflammation and edema follows. Lymphocytes infiltrate the peribronchiolar area, and clinically we have a viral tracheobronchitis. The imaging findings at this stage consist of thickening of the axial interstitium, bronchial wall thickening, which can be appreciated on a radiograph primarily as thickening of the ring structures, best appreciated usually in the perihilar region. This can be a tough call, but on the high-resolution CT to your right, we can clearly see that there is thickening of the bronchial walls. We can see both ring structures and bronchial walls in the plane of section recognizable as tram tracks. And we also see bronchiolar impaction. These small centrolobular dots, some of which are forming V and Y-shaped structures, represent bronchioles which are impacted by inflammatory material and cells, causing a tree in bud appearance. This is a viral tracheobronchitis. The second phase of a viral pneumonia is when the inflammation extends to the interlobular septi. In the interstitium, there's an accumulation of infected cells, lymphocytes, and edema, and the imaging correlate of this stage of the disease is ground glass densities and septal thickening. This is another more advanced viral pneumonia. Radiographically, we see hazy, increased lung density with a superimposed meshwork of reticular markings representing the septal thickening, and the correlate on CT shows, again, regional areas of ground glass attenuation showing, representing the lung inflammation, with septal thickening representing the accumulation of inflammatory cells in the interlobular septae and intralobular septae. And the final phase of the viral pneumonia is when the alveolar walls and the air spaces are now involved by hemorrhagic edema, hyaline membrane formation, and migration of PMNs into the air spaces. The imaging correlate here is perihilar ground glass and consolidation and acinar nodules, which can become quite confluent. This is an NYU undergraduate, a young woman who came in with a bad viral pneumonia. We can see not only does she have ground glass, such as we saw in the preceding patient, but she's gone on to dense consolidation in regions such as her right upper lobe. And here we can see ground glass densities and acinar nodules becoming confluent airspace disease in a somewhat perihilar distribution. Pneumocystis carinii pneumonia is another atypical pneumonia. It is quite common in the immune-compromised host. In fact, it's 40% of pneumonias in that setting. And in general, the immune compromise in these susceptible patients is due to impaired cell-mediated immunity. So we're talking about the AIDS population, patients being maintained on high-dose steroid therapy, and patients with malignancy, and in particular, patients who are immune suppressed because of transplants. Both solid organ and bone marrow transplant patients are maintained on prophylactic therapy routinely because of the high risk of PCP pneumonia. When it occurs, particularly in the bone marrow population, it is a rapid, fulminant, progressive disease with a very high mortality. Because of the maintenance prophylaxis, mercifully, the incidence is fairly low. In the setting of AIDS, we should just note for a moment that really the PCP incidence has changed considerably. Before HAART therapy, highly active antiretroviral therapy, PCP occurred in 60 to 70% of AIDS patients, and in fact, it was the index diagnosis in 40 to 50%, meaning it was the diagnosis that established the diagnosis of AIDS. With HAART therapy being widely used in the United States, at least, there's been a marked decrease in the incidence of PCP, although it does remain the most common opportunistic infection in the AIDS population. Breakthrough cases do occur. It is unusual with a CD4 count greater than 200, and in fact, discontinuation of prophylactic therapy is probably appropriate when the CD4 count does creep up over 200 with HAART therapy. Again, the infection moves through phases with the inhalation of the infectious particle, in this case, the trophozoite form of the organism. There's infection and killing of the type 1 pneumocytes. The alveolar spaces fill with exudate, fibrin, dead cells, the cysts, and trophozoite forms of the organisms. And the imaging correlates here in the early phase of the disease is hazy ground glass densities in the mid and upper lungs with a somewhat perihilar distribution. This is not hard and fast, but generally it tends to be upper lung early on. The imaging CT correlate here, again, shows regional zones of ground glass attenuation. I'll stop for a moment because I realized I'm using the term ground glass and I haven't defined it. For those of you that don't do a lot of lung imaging, it's a term in our lexicon which describes hazy increased density such as this through which you can still see the underlying anatomic structures. I've lost my arrow. So we're talking about like a smoked glass, like a Absolute vodka bottle or a Grey Goose vodka bottle, that smoky appearance. This is another patient with a ground glass appearance of PCP with slightly increased interstitial reticular markings, interlobular septal thickening, very typical areas of lung involvement interspersed with areas of uninvolved lung. And the path correlate of this is partial filling of the alveolar spaces by this frothy exudative material in conjunction with inflammation and infiltration of the alveolar walls and the septae by inflammatory cells and fluids. So the walls are thickened, the air spaces are partially filled by this exudative material, and when we do silver stain, we see the cyst form of the organism filling the air spaces. The next phase is the reparative phase of PCP, when the lung type 2 pneumocytes start to proliferate in a reparative attempt. There is migration into this interstitium of macrophages and monocytes, and because of this, we start to see more reticular opacities and interstitial thickening. So here we have ground glass densities, again, with an overlay of reticular markings. This patient, in the acute phase of the disease, we can see ground glass densities, and as we come into the subacute phase of the disease, the areas of ground glass have transformed into areas of reticular changes with a little bit of architectural distortion. Legionella. This clinically is an unusual disease in that there's a lot of systemic findings. Headache and diarrhea are very typical. Tends to be a febrile illness preceding the pneumonia. When the pneumonia comes, it's often accompanied by pleuritic chest pain and a productive cough. Tends to occur in those older than age 60, smokers and alcoholics in particular. The imaging is generally consolidation in the upper lungs, starts out segmental, rapidly progresses to lobar consolidation, and rapidly becomes multilobar and bilateral. So we have a patient with patchy areas of segmental and subsegmental consolidation on the 19th, which by the 24th has progressed to dense consolidation with a pleural effusion. This is a different patient with Legionella pneumonia. Bilaterally, this happens to be a young woman, which is a somewhat atypical clinical presentation, but she had Legionella presenting as ground glass densities with some patchy areas of denser consolidation forming in the right lower lobe. But note there is pan-lobar involvement, in this case associated with a small effusion and some reactive adenopathy in the hilar region and the subcarinal region. Moving now to somewhat pedestrian garden variety causes of acute lung syndromes. We're going to talk about edema and less commonly ARDS. These are physiologic causes, in fact, very common causes. Beginning with hydrostatic edema, pathologically, as we move from early to mid to late hydrostatic edema, we get edema in the peribronchovascular lung, then spreading to septal edema, formation of pleural effusions at this stage, and finally, airspace involvement with alveolar flooding. So early on, when there is perivascular edema, we see indistinct vessel margins with bronchial cuffing. Then we start seeing septal thickening, correlate being the curly B lines and curly D lines. Late stage airspace opacities, ground glass opacities. So early on, this is a supine patient, but we see indistinct perivascular edema, making the vessels a little bit indistinct and hazy. There's bronchial cuffing. The CT correlate shows increased density in the peribronchovascular interstitium. There's a little bit of thickening of the bronchial walls, 5 millimeter image, and perhaps better appreciated on the 1 millimeter image here. There's a little bit of interlobular septal thickening. So this is early pulmonary edema. Just as a note, sometimes when you're looking at a high-res CT, you lose your anatomic orientation because of the very thin section. So this is a 1 millimeter thick section and a 7 millimeter thick section. And the perihilar, perivascular distribution of edema is in fact arguably better appreciated on the 7 millimeter thick section because you can better appreciate the orientation in the lung. With the thicker section. With moderate edema, we see more interlobular septal thickening superimposed on the ground glass densities, and at this point we start to see pleural effusions. And this is a chronic edema. This patient has interlobular septal thickening and diffuse ground glass throughout the interstitium. This patient had long-term edema. Non-cardiogenic edema can be looked at in terms of etiology as due to 3 broad categories of disease. It could be due to increased capillary permeability, increased vascular pressure, or decreased oncotic pressure. And there's a host of entities that fall into each of these categories. I'm not going to read this list, but there's a lot of entities which cause the capillary permeability to increase with seepage of fluid into the lung due to that. Vascular causes, some of these overlap. Neurogenic edema causes both capillary permeability and increased vascular pressure. Increased vascular pressure is also noted when there's breathing against positive pressure. This can happen with laryngospasm as a drug reaction. It can also happen with strangulation and hanging injuries, suicides, and so forth. Finally, decreased oncotic pressure can happen, first of all, when there's fluid overload with a hypotonic fluid, but also if there's hypoproteinemia, either due to nephrotic syndrome, protein losing situation, or if there's liver disease and hypoproteinemia due to that. This is a patient with renal failure. This is a non-cardiogenic edema. In distinction to the edema pattern we saw previously, note that there is no particular peribronchovascular, perihilar distribution of the disease. Note that the upper lung veins are not distended, in contradistinction to this patient who has CHF, where the upper lung veins are grossly distended. This is another patient with renal failure and non-cardiogenic edema, more advanced, showing, in fact, airspace flooding. But note the very sort of patchy distribution of this edema, which is quite atypical of hydrostatic edema. There's relatively little involvement of the left upper lobe and a lot of edema, for instance, in the left lower lung. Permeability edema, which is what we're talking about, can occur with diffuse alveolar damage or without diffuse alveolar damage. When we see it without diffuse alveolar damage, we simply are looking at edema that happens because there's widening of the capillary endothelial cell junctions, and a classic paradigm for that would be an opiate overdose, heroin, methadone. With diffuse alveolar damage, and I'm going to explain what that is in a moment, there's much slower clearing because not only do we have the widened capillaries, but we have alveolar and endothelial cell damage. So this clears much more slowly, and the paradigm for that would be ARDS, acute respiratory distress syndrome. Not to focus too much on the pathology, but diffuse alveolar damage is one of the relatively limited responses of the lung to injury. And when there's injury to the alveolar and endothelial cells and edema formation, hyaline membranes form, and you go with DAD, you go through an exudative, proliferative, and then a fibrotic stage, which is typical of many insults to the lung. If it's idiopathic, the example would be acute interstitial pneumonitis, AIP. Known causes for diffuse alveolar damage would include radiation, pneumonitis, ARDS, such as we're talking about now, many drug reactions, drug toxicities, for instance. Risk factors for ARDS: trauma, sepsis, pneumonia, aspiration of gastric contents, fat emboli, transfusion reactions. Clinically, ARDS presents as acute respiratory failure, profound hypoxia. There is severe hypoxemia with AV shunting. The lungs become stiff and non-compliant and requires high-pressure ventilation. It goes through stages: exudative, proliferative, and fibrotic, and the imaging correlates follow along with interstitial edema. This is a patient with staph sepsis. Note that there's ground glass densities bilaterally, patchy areas of consolidation. The imaging findings are that the densities tend to be peripheral, such as we're seeing here. Oftentimes there are air bronchograms, such as we're seeing here. The upper lung vessels are constricted. I apologize for the motion here, but obviously this patient is quite sick. The upper lung vessels are quite constricted. Lung volumes tend to be low. This patient is not yet intubated, but barotrauma because of intubation with these stiff, non-compliant lungs is very typical. Note the absence of pleural effusions, cardiomegaly, and septal lines, a differentiation point between ARDS and pulmonary edema. MENDELSO'N's syndrome describes the aspiration of gastric contents. The acidity of the gastric contents causes vascular permeability and non-cardiogenic edema, as we just saw. Typically, there may be a superimposed pneumonia forming. This is a young woman who just had an emergency cesarean section, and aspiration occurred, and we have dense consolidation, pleural effusions. Moving now to iatrogenic causes of acute lung syndromes, we're going to discuss briefly radiation pneumonitis and drug reactions. When considering radiation pneumonitis, there's a number of variables. You need to consider the volume of lung that's irradiated, the dose that's been delivered, and the delivery schedule, actually, the treatment shape of the treatment field, the time period in which it was delivered, whether there was concomitant chemotherapy, and individual susceptibility plays a factor. Radiation is rare if less than 3,000 centigrade are delivered, variable between 3,000 and 4,000, and quite usual over 4,000. Acute radiation pneumonitis occurs 1 to 4 months post-treatment. Histology, diffuse alveolar damage, alveolar proteinaceous exudate, hyaline membrane formation, and symptomatically the patient will present with cough, fever, and dyspnea. The imaging findings are going to be recognizable as increased attenuation within the radiation ports. Generally, early on, this will be appreciated as ground glass opacification, patchy areas of consolidation, and because it's within the radiation ports, it's going to be non-anatomic in distribution. If you see increased attenuation beyond the radiation ports, you have to consider whether there's scatter radiation or hypersensitivity pneumonitis, as has been described in some cases. In this setting, you need to differentiate this process from infection, tumor recurrence, or drug toxicity. And you do so by, again, considering the port and the appropriateness of the time frame. The caveat, radiation pneumonitis is PET positive, so PET imaging isn't necessarily going to be helpful to differentiate these processes. Here we have a patient with esophageal cancer, and we see acute radiation pneumonitis as ground glass and denser lung consolidation in this unusual paravertebral distribution. In this patient who also had central radiation, you can see some hazy ground glass here and a somewhat nodular area of consolidation, a less typical but not that unusual presentation for radiation. This patient had lung cancer with radiation to the hilar regions and quite a bit of scatter radiation out to the periphery of the lung. So although I have emphasized that you should look for the radiation pneumonitis in the port, you can get scatter radiation in the periphery of the lung. Another patient who had a left upper lobe resection and left hilar radiation after the surgery has quite a bit of radiation pneumonitis throughout both lungs, scatter radiation. Drug-induced diseases, I'm not going to go through this slide, but the point here is that if you look through this list, there's a lot of overlap not only in the different drugs that cause all of these processes, but there's a lot of overlap in the processes themselves. Whoops. So fibrosis, pneumonitis, hypersensitivity, non-cardiogenic edema, ARDS, bronchiolitis obliterans, all of these can be caused by a spectrum of drugs. This is a cancer patient presented with acute severe dyspnea, a lot of hazy ground glass in his radiograph, some denser consolidation here, and we see hazy areas of increased density, primarily peripheral in distribution. This was due to a drug toxicity from gemcitabine. I should thank Paige McAdams for giving me this case. He's down at Duke. It's important to consider in your differential in a cancer patient presenting with acute shortness of breath, drug reactions as we saw, infections as we've also seen, particularly PCP, hemorrhage in the lung, and radiation pneumonitis in the appropriate setting. Collagen vascular diseases, I'm only going to talk this morning about lupus. There's a spectrum of diseases that can occur in the lungs of a lupus patient, including diffuse alveolar hemorrhage, atelectasis, infection, lupus pneumonitis, and pulmonary hypertension. I'll focus briefly on diffuse alveolar hemorrhage and lupus pneumonitis. Lupus pneumonitis causes an acute abrupt onset of dyspnea, fever, and cough. It is an immune alveolar capillary injury. Vasculitis is unusual. There is a high mortality, and there's a variable response to steroid therapies. It's a hard diagnosis to make. This is an acute lupus pneumonitis presenting primarily as ground glass opacities and small punctate nodules. Bronchial wall thickening, bronchiectasis, and fibrosis can also be seen in this disease. This is the same patient. The image in the lower right is this patient 10 days after steroid therapy. This person got a very nice response to steroids from his lupus pneumonitis. This is a different patient with a slightly different pattern of lupus pneumonitis. In this case, we're seeing more ground glass opacities, and here we see bronchial wall thickening as a component of his disease. And again, I don't have the follow-up CT, but here was the X-ray on presentation with a lot of hazy increased lung density, and post-steroids 10 days later, there's a lot of clearing. Idiopathic lung syndromes that can present acutely include the spectrum of hemorrhagic syndromes and acute interstitial pneumonitis. Hemorrhagic syndromes localized can be due to cancer, bronchiectasis, or infection, but I'm going to focus this morning on the diffuse alveolar hemorrhage syndromes, vasculitis such as Wegener's, lupus we just saw, and autoimmune diseases such as Goodpasture's, and idiopathic diseases such as idiopathic pulmonary hemosiderosis. IPH, idiopathic pulmonary hemosiderosis, tends to occur in children and young adults, characterized by episodic alveolar hemorrhage. The path is quite nonspecific, diffuse alveolar hemorrhage, and we see, is really a diagnosis of exclusion, we see on imaging ground glass densities and septal thickening. So this is a patient presenting acutely with idiopathic pulmonary hemosiderosis, ground glass, septal thickening. There's a chronic component to this disease with repeated episodes of bleeding. There'll be fibrosis. There's probably a little traction bronchiectasis here and architectural distortion. But in other areas of the lung, we see ground glass densities and septal thickening. Again, this disease is characterized by repeated episodes. Goodpasture's syndrome is an autoimmune disease with antiglomerular basement membrane antibodies. The renal disease occurs in 100% of patients with Goodpasture's. The pulmonary disease occurs somewhere around 60 to 80%. Young adult males are the typical population, and it can be a quite similar finding, pulmonary hemorrhage. Ground glass densities, central lobular thickening, and some septal thickening in this patient in a very peripheral, strikingly peripheral distribution, both radiographically and on CT. So, having run quickly through a host of disparate processes that can cause a patient to present in the emergency room with acute dyspnea, I wanted to then try to put together the CT signs in order to allow one to narrow the differential considerations. I will not go through this whole list, it is in your syllabus, but when we look at the spectrum of CT findings, again, there's a fair amount of overlap, but you can narrow the differential considerations down. For instance, there's only a few entities which necessarily cause bronchial wall thickening, septal thickening without architectural distortion, think about edema and pulmonary hemorrhage, and so on. So as you run through these, the spectrum of CT signs, you can narrow your differential considerations, and then in particular, if you start to integrate clinical parameters, you can further refine the differential. For instance, you should know what disease processes would be typical of an immune-competent patient. That would include infection, edema, ARDS, drug toxicity, hemorrhage, collagen vascular disease, and AIP, whereas in an immune-compromised patient, you probably should think infection and drug toxicity first, and in the appropriate clinical setting, radiation pneumonitis. So integration of clinical findings is going to be helpful. Acute dyspnea is daily a clinical challenge caused by a spectrum of diseases. This is something we see every day. The chest x-ray findings can be quite subtle or nonspecific. I know that's blasphemous, but it's true. And CT findings can add specificity, which in conjunction with the clinical features can significantly narrow the differential considerations. And although I ran through and laid on you a host of different processes, I hope this will be helpful to you. Thank you very much.